Uh, just to remind you, the HER2 positive breast cancer represents 14% of the cases of breast cancer. And of course, this category of the patient has a worse prognosis compared to the other category of the patients. So we will start with the patient who did not receive neoadjuvant therapy. We have to divide this category of the patients into high-risk patients and low-risk. So the 10-year report found that there is similar disease-free survival and overall survival for both anthracycline and non-anthracycline containing protocols, 83 versus 85% for the overall survival, 10-year overall survival. And this, of course, better than the protocols did not containing Herceptin. And they concluded that we can omit anthracycline from the protocols of the HER2 positive breast cancer to have the advantage of less arthralgia, less myalgia, stomatitis, vomiting, of course, less leukemia, and the most important, less cardiac events. Important questions. Do all patients need anthracyclines? In the category of HER2 positive disease, either node negative or node positive, either in the adjuvant setting or neoadjuvant setting, we do not need anthracycline anymore. We can omit anthracycline from the treatment of HER2 positive disease. So, what's the optimum duration of the Herceptin in the adjuvant setting? To answer this question, we have to look to this important trial, which is the HERA trial, which studied the difference between chemotherapy without any further anti-HER2 treatment, or trastuzumab for 1 year, or trastuzumab for 2 years. And as we can see, there is a significant advantage from adding trastuzumab for 1 year, with almost 7% increase in the disease-free survival, and there was no any advantage from extending the duration of trastuzumab to 2 years. So they concluded that trastuzumab is standard of care, and the 1 year duration is enough to achieve the advantage. What about the de-escalation strategies? What about shorter duration of trastuzumab? We have 5 non-inferiority randomized controlled trials which compared the trastuzumab 12-month, the standard of care, versus shorter duration, 6 months or even 9 weeks duration. So all these trials did not reach the inferiority margin, except one trial, which is the Persephone trial. However, when we look to the hazard ratio, we found that the difference is not that big. So until now, the recommended duration is 12 months. This is the standard of care. However, if there is toxicity from the trastuzumab, or if it is not available, we may consider shorter duration without market compromising compromisement of the result. Back to the landmark BCI RG006, and as we said, after 10 years of the follow-up, there is a market advantage from adding Herceptin to the chemotherapy, and there was no difference between anthracycline and non-anthracycline containing protocols. However, with chemotherapy and with Herceptin, still there is 25% of the patient experienced events at the 10-year follow-up, which means 1 in 4 patients will have a event, either relapse or metastasis or death within 10 years. This suggests that we need further treatment, and this is what's the rationale to trial to escalation strategies. So we have the affinity trial, which tried to escalate the treatment with adding pertuzumab to the trastuzumab to get the synergistic activity. And before we go for the affinity trial, we will discuss rapidly the mechanism of action of the pertuzumab, which is monoclonal antibody against the HER2 receptor. And to understand the mechanism of action, we have four EGFR receptors in the breast cancer, which is HER1, HER2, HER3, and HER4. And these receptors have to combine together in a very important step before activation, either with the same receptor, which is called homodimerization, or with different receptor, which is called heterodimerization. So both monoclonal antibodies, trastuzumab and pertuzumab, bind to the extracellular domain of the HER2 receptors, but in different regions. So the trastuzumab inhibit the proliferation through direct antibody binding activity, which is antibody-dependent cellular cytotoxicity, and by HER2 downregulation. But pertuzumab bind to the dimerization domain of the HER2 receptor, prevent the block the heterodimerization with other HER receptors, and thus and by this it synergizes the action of trastuzumab. Go back to the affinity trial. It's a larger trial, included around 5,000 patients, which were randomized to receive chemotherapy plus Herceptin, pertuzumab, or chemotherapy plus Herceptin and placebo. And the endpoint was the invasive disease-free survival. And we mean by invasive disease-free survival that we exclude in situ events and include regional recurrence, ipsilateral breast cancer recurrence, contralateral breast cancer recurrence, death from any cause, or distant recurrence from cancer. So, what's the result? The result at the third interim analysis, after 8 years of follow-up, there was an increase 2.6% in the disease-free survival, with hazard ratio 0.77, which means that there is 23% risk reduction compared with placebo Herceptin. Is this enough? When we look to the subgroup of the patient with no positive disease, we have a marked difference with clear advantage from the adding of pertuzumab. So in no positive subgroup of the patient, there is 5% increase in the disease-free survival at 8 years of follow-up, with 28% risk reduction at the third interim analysis. What about the node-negative subgroup? They did not have any advantage from adding pertuzumab, and they continue to do well without pertuzumab. 93% of the patients in both treatment arms were event-free at 8 years after randomization. So, does hormone receptor status differ from adding progestin? No. The answer is no. Hormone receptor positive subgroup and hormone receptor negative subgroup both get the same advantage from adding pertuzumab, with almost 25% risk reduction in hormone receptor positive and 18% risk reduction in hormone receptor negative patient. So the Perjeta Herceptin treatment is not dependent on the hormone receptors of the primary tumor. What about the overall survival in the affinity trial? Still, the data are immature. Only 58% of the target achieved. However, after 8 years of follow-up, there is a trend toward overall survival benefit with Perjeta. The overall survival without Perjeta is 92%, and the overall survival with adding Perjeta is 92.7%, with 0.7% increase in the overall survival in the all population. However, this difference is referred again to the node positive subgroup of the patient, which achieved 2% difference in the overall survival at 8 years, with hazard ratio around 0.8%. So another important question is regarding the toxicity. We add another anti-HER2 treatment, so we may think that the cardiac toxicity will increase, and actually it increased, but to that not to that serious limits. So as we can see in the pertuzumab containing protocols, the primary cardiac events are either heart failure or cardiac death is around 0.8%, and in the placebo Herceptin arm it's around 0.4%. So in this interim analysis, no new cardiac safety issues emerged. And when we look to the subgroup of the patients received anthracycline, we found anthracycline with Herceptin pertuzumab protocol is the highest regarding the cardiac toxicity with 0.9%, and non-anthracycline containing protocols with pertuzumab, the cardiac events is only 0.4%, which indicate that the anthracycline is the main cause of cardiac events in such. So to conclude the affinity trial, pertuzumab has trend toward the overall survival benefit, and this trend is influenced by the node-positive cohort of the patient. The node-positive cohort drives disease-free survival benefit from adding pertuzumab. Node-negative patients did not have a benefit from adding pertuzumab. Hormone receptor status should not guide pertuzumab treatment decision in adjuvant setting, and no new cardiac safety issues emerged till this time from adding pertuzumab. So, depending on this trial, the guidelines, St. Gallen, NCCN, the German, and the ASCO guidelines all included Perjeta to the Herceptin in a high-risk patient of the relapse in the adjuvant setting, and they defined the high-risk patient by those patients with positive lymph nodes. Some guidelines added the patients with HER2 negative disease and the high risk patient. Back again to the patients who did not receive neoadjuvant therapy, and we will talk about the low risk patients, and we will define the low risk patient as the patient with node negative disease and with tumors less than 3 centimeters. We have this famous APT trial, adjuvant paclitaxel and trastuzumab. It is just a phase 2 trial done on 400 patients. They give the patients with low risk tumors less than 3 centimeters, node negative tumors. They give only paclitaxel for 12 weeks with trastuzumab, followed by trastuzumab for 1 year. We have to look to the data. We find that almost 91% of the patients have tumors less than 2 centimeters, and only 9% of the patients have tumors more than 2 centimeters and less than 3 centimeters. The results of this trial is very impressive. Only 6 events happened at 3 years, and this was a very good result. So, although this is only phase 2 trial and is not supported by randomized phase 3 trials, however, guidelines accepted this protocol for this category of the patient with low risk T1N0 in adjuvant. So, what about the patient who received neoadjuvant therapy? To answer this question, we had to look for the past few years. For the past few years, newly diagnosed HER2 positive breast cancer who received neoadjuvant treatment then underwent surgery, and the result after surgery will be either PCR or residual disease, and both categories of the patient will receive the same treatment of Perjeta Herceptin or Herceptin alone for 1 year, and there is no evidence to support changing the. However, we know all that there is a difference in disease-free survival and in the overall survival between the patient who achieved PCR after neoadjuvant therapy and those who have residual disease. This, taking this with the results of Creatix study, which found a significant difference from adding Zeluda to those patients of triple negative breast cancer who did not achieve PCR. The Catherine study tried to optimize the therapy by changing to Kadcyla in the patient who have residual disease in breast or axilla following neoadjuvant Herceptin containing therapy. And before we go to the Catherine study in details, we will remind you with the Kadcyla molecule, which is an antibody drug conjugate molecule containing the trastuzumab as monoclonal antibody linked with a stable thioether ether link to the DM1, which is a cytotoxic drug working by tubulin destabilization, and it is 20 to 100 times more potent than vincristine, almost 200 times more potent than other chemotherapy like paclitaxel. So how does it work? It works by that trastuzumab, the monoclonal antibody, will bind to the HER2 receptor, and it works by the usual mechanism of the trastuzumab by antibody-dependent cellular cytotoxicity to inhibit the cell proliferation, and by another mechanism when this molecule with internalized it underwent degradation by the lysosomal enzymes and release the cytotoxic molecule, which is the DM1, and the DM1 inhibit the microtubular assembly, leading to the cell cycle arrest and apoptosis. So it has double action: the monoclonal antibody action by trastuzumab and the cytotoxic drug action by inhibiting the microtubule. So back to Catherine study, which try to optimize the therapy according to the response of neoadjuvant treatment. So the patient who HER2 positive patient who received neoadjuvant chemotherapy plus Herceptin with or without Perjeta then underwent surgery and had residual disease either in the breast or the lymph nodes, and they did not include those patients with carcinoma in situ. The residual must be invasive tumor. Those patients were randomized to receive either Herceptin or to receive Kadcyla for 1 year. So what is the results? The results is impressive. We have almost 11% increase in the disease-free survival at 3 years follow-up. The hazard ratio is 0.5, which means that the Kadcyla reduced the risk of invasive disease-free survival events by 50% compared with the Herceptin. Of course, the major disease-free survival events were the distant deaths, and so we have fewer distant recurrences occurred with the Kadcyla with hazard ratio 6. Looking to the subgroups, all subgroups of the patients get the benefit from adding Kadcyla in patients who had residual disease, either hormone receptor negative or positive, either node negative or positive, either received Herceptin only in the neoadjuvant setting or Herceptin projected. So, what about the overall survival? The overall survival data is still immature. However, it supports the primary endpoint of disease-free survival. The hazard ratio is 0.7, with only 42 events in the Kadcyla group versus 56 events in the Herceptin group. So, what about the toxicity of the Kadcyla? Of course, as we said, the Kadcyla is conjugation between monoclonal antibody and cytotoxic drug. So, we may think that this Kadcyla will have more toxicity than the Herceptin alone. And of course, This is the truth. However, more than 70% of the patient in the Kadcyla group completed the 14 cycle of the Kadcyla treatment. The other 30% did not complete the 14 cycle, and the most common cause for Kadcyla discontinuation were due to laboratory abnormalities, mainly platelet abnormalities. And as we can see here, the platelet count decrease happened in 5.7% of the patient with Kadcyla group versus only 0.3% in Herceptin. However, the higher instance of decreased platelet count did not match with the hemorrhage. The grade 3 hemorrhage were similar between both groups. Other causes of discontinuation were the increased liver enzymes, the peripheral neuropathy, and so on. This is the side effects happen more than 1% with grade 3. So the grade 3 events and more happened in 25% in the Kadcyla group versus only 15% in the Herceptin. Of course, more in the Kadcyla group. And the serious adverse events happened in 12% in the Kadcyla group versus only 8% in the Herceptin group. And the discontinuation were more in the Kadcyla group than the Herceptin group. So again, the important question: what about the cardiac safety? The Kadcyla is just like Herceptin, it's monoclonal antibody plus chemotherapy, so the incidence of cardiac events was low in both arms, maybe lower in the Kadcyla group numerically, but not significantly statistically, not significant statistically. Based on this trial, all all guidelines recommended the TDM1 for 14 cycles of residual invasive disease after new adjuvant treatment for HER2 positive disease. So to summarize the treatment algorithm of HER2 positive disease, we have this from the ESMO. This slide from the ESMO. If the tumor is less than 2 centimeters and non-negative, we can go for upfront surgery. And according to the result of the surgery, if the postoperative pathology is stage 1 with tumor less than 2 centimeters and non-negative, we can go for the adjuvant low-risk protocol, which is paclitaxel for 12 weeks with Herceptin, followed by Herceptin for 1 year. And if we can, if we have a higher stage 2 or 3, we go for the standard protocol, which is either Taxotere, carboplatin, Herceptin with or without Perjeta, or AC followed by paclitaxel, Herceptin with or without Perjeta, and Perjeta should be added in the patient with node-positive disease. The anti-HER2 treatment will be continued after the chemotherapy for 1 year. And if we have tumor more than 2 centimeters with node negative, or we have node positive disease, we should go for new adjuvant treatment with TCHP protocol or ECT HP protocol, anthracycline or non-anthracycline protocol. And of course, we would prefer to get a non-anthracycline protocol to avoid the cardiac toxicity. Then we will go for surgery. Then after surgery, if we don't have PCR, so we should go for the TDM1 for 1 year to complete 1 year. And if we achieve the PCR, we should continue for the anti-HER2 treatment for 1 year with either Herceptin alone or Herceptin Perjeta if the patient had positive lymph node. But I have finished my talk, and thank you for your time.